Good evening, everybody. I'm Michele Andrews. I'm your American Heart Association instructor who you decided might be able to help you while you study and prepare for your ACLS class and test. And that's exactly what I'm going to do, and I'm going to do it quickly. So pay close attention. I hope you have your PDF printouts in front of you. If you were having trouble with the PDF printouts, at first they might come out too big for the page. Just make sure that when you go into print, you click the link that says additional settings, and then that's where you'll have the option to fit to page. That's what you want to choose, fit picture to page, and then go ahead and print, and the picture will print out as such. Okay? So that was one of your printouts. Okay, so that was one thing I did want to go over because I had the same problem. They came out, they were huge, and so I was only getting a portion of that printout. And so then I went into my settings after I hit print. It came up with advanced options for print, and it said fit picture to page, and I hit that, and then I hit print, and it came out right on the page. So that's what you need to do. Once you have those PDFs in front of you, we're ready to roll. Make sure you have an extra piece of paper, or you can just take some notes on the back of this PDF printout, because really everything that you're going to need is already printed out for you. But what I like to start with is talking about what is ACLS really encompass. The book is laid out in chapters, and so you have a STEMI chapter, which they call acute coronary syndrome. They have a stroke chapter. They have airway management chapter. And then the rest of the chapters really encompass what I call, for short, AHRs, abnormal heart rhythms. Because if it's not a normal sinus rhythm, it is an abnormal heart rhythm, right? So that's what you're going to hear or see me write. And you might actually see that on one of the PDF printouts. I'm not sure. Yes, you do. You do. On one of them, in the little heart in the bottom right-hand corner, you'll see AHR. That stands for abnormal heart rhythm. And you see the 4 arrows pointing to that. Okay? So just write that right beside it, abnormal heart rhythm. So the 4 areas that encompass ACLS really are STEMIs, strokes, airway management, and abnormal heart rhythms. So you have those 4 written down. So let's talk a little bit about STEMIs. What does American Heart expect me to know regarding STEMIs? Well, first and foremost, signs and symptoms of an acute coronary syndrome patient. Not just your average elephant on my chest, I can't breathe, I'm short of breath. Although in the questions, they often do say the patient has had some shortness of breath and chest pain. So there you go. They're giving you a clue there in that question. All right. Then also you want to remember some of the other signs and symptoms for your clinical work that you do in the hospital. You want to be able to pick up on these things. If you work in the ER and you have a patient come in with scapular pain and it's radiating around a little to the side, you might want to suggest an EKG. Simple, cheap. Let's get one done. Make sure we're not got some sort of a cardiac issue going on. How about some right arm pain, some jaw pain? How about nausea? along with shortness of breath, these sorts of things. Don't overlook a possible life-threatening, life-altering, easy to fix problem. Because I myself, in my family, have had that happen. It got overlooked in the ER. And he died. He had a massive heart attack and died after going to the ER twice with the same symptom. Scapular pain radiating around. No EKG was done. No blood work was drawn. So it happens, right? And you want to catch them. You want to be the one that catches those. It could be someone you love. But even if it isn't someone you love, it's someone that is loved. And you could save their life. Now, knowing the signs and symptoms is huge and very important in American Heart Association, right? Remember, in those questions, they're going to oftentimes add some sign or symptom of a STEMI or acute coronary syndrome patient. And so they're kind of giving you the answer. All right? So they're veering you. Start veering your mind once you see that. Shortness of breath, jaw pain, nauseous with shortness of breath. And when you see those sorts of things, I want you to go ahead and start having your mind go towards, this has something to do with the heart, cardiac. Okay. Now, the next thing that you need to know about STEMIs is how to identify them, right? And as I go through the abnormal heart rhythms, you're going to understand what I mean more and more. But each little piece of the QRS wave, the PQRS-T wave, it all represents something that's going on inside the heart. And so the T wave typically looks pretty normal. If you look right around here, let me get my pencil so I can show it to you better. Okay, I want to make sure you can see this. So if you look, and you look right about there, that's what a T wave should look like. See how it's on the baseline? It's on the baseline. And it's small, right? It's small. But if you come down here and you see a T wave that's not on the baseline, it's very tall and it's very wide. That T wave is the culprit. And it represents a cardiac issue. Okay? So when you're looking at your PQRS-T, ST, T's typically should be small. If they're tall and wide, you have a cardiac issue. Okay? It can be above the baseline, and it can also be below the baseline in a lead where it should normally be above the baseline. Do you understand what I mean there? Lead Roman numeral 2 is what we normally show our telemetry in. And therefore, our P, our QRS, and our T are all above the baseline. They stand up straight. Okay? Such as you see right here. All right? Now, I want to make sure you can see that. I'll pull this back. Such as you see here. But let's say that this also, this STEMI here, is in Roman numeral 2. And we see that the S and the T is above the baseline, above the baseline. What if it was flipped down and below the baseline, but we're still looking at it in the Roman numeral 2 lead, then that is a ST segment depression. So you can have ST segment elevation, you can have ST segment depression. So you can have it up, or you can have it down. It can be flipped upside down. You can also have a STEMI with an abnormal looking T, where the rest of the rhythm looks pretty normal. So again, putting it all together, look at the patient first, listen to what they say and what their complaints are, and then get that EKG and take a good hard look at that ST segment. Is it elevated? Is it depressed? Is it rather normal but possibly widened in the T area? Because all three of those can be signs of a STEMI as far as being able to recognize them. So we have learned that American Heart Association wants us to be able to recognize signs and symptoms. They want us to be able to recognize what a STEMI might look like. They're not going to give you anything really hard. Don't be scared of that. On the test, if they asked you to recognize this rhythm, it's going to be a rhythm that looks really textbook, okay? I feel like this little light right here might be a problem, but right here, let me grab my pencil. Right here, it's going to look something like that. Very textbook. As a matter of fact, you have these rhythms in your PDF printouts. It's number... Oh, it's number 14. So number 14, it'll be textbook, okay? But you still need to know that a STEMI could be depressed, all right, as well. The next thing that you need to know quickly about STEMIs, because I've spent too much time already on it, and I didn't want to spend this much time, is as I look through the things that American Heart asks us to know about STEMIs, is they might ask a question, something like, what do you think the recommended dose of aspirin is to a patient with a suspected acute coronary syndrome? That would be a question that I could see American Heart asking. What's the expected dose of aspirin? What's your guess? Because if you don't know, write that off to the side. I need to look up what the dose is, or I can just give you the answer. And the answer is about 160 to 325 milligrams. Okay? So that is a question that I could see on the test. Again, they might ask you questions that kind of lead you to believe that we're talking about a cardiac issue. He's short of breath, his blood pressure is 95/65, his respirations are blah, blah. What do you think the first thing we should do is? Well, the fact that he was short of breath and had chest pain, boom, EKG is going to be your answer. So it's pretty easy if you can look into the question and kind of know what direction they're heading in. It's one of four areas. STEMIs, strokes, airway management, or an abnormal heart rhythm. Okay? All right. So that's really what I have to share with you about STEMIs. There is one that I wanted to go over, and it's kind of a post-cardiac arrest. It just talks about what's the minimum systolic blood pressure one should attempt to achieve with fluid administration in a hypotensive post-cardiac arrest patient who achieves return of spontaneous circulation. In other words, you resuscitated them, You got them back. So now that they're back and their heart is beating on its own, what is the minimum systolic blood pressure you should attempt to achieve? And that answer is 90. 90. Okay? So that's a question I could definitely see them asking. And that's kind of a post-cardiac arrest question. There's another post-cardiac arrest question that I could see. And it's one really that all you ICU nurses know. If someone needs to be resuscitated, once they've returned to spontaneous circulation and they're taken to the cath lab, we've gone ahead and provided that stent. All is well. They're on their way up to ICU to be cared for until they go to step down. What happens in the ICU is a lot of times we put them into purposeful hypothermia at 32 to 36 degrees Celsius. That's important. You need to know that. Once they've returned to spontaneous circulation, we put them into purposeful hypothermia at 32 to 36 degrees Celsius. For how long? Good question. 24 hours. Okay? And that's what you need to know about STEMIs. It's important to know that out in the field, we have a possible STEMI. Where do you think the EMS should take the patient? Well, wouldn't you think the answer, just common sense, would be to a hospital that has a cath lab? And that would be the correct answer. Not the closest hospital, but the closest hospital that has a cath lab. And those are easy questions. So I don't want you to make it hard. And those are about all the STEMI questions that you'll see on there. And I'm going to move on to strokes now. It's kind of the same thing as it is with STEMIs. American Heart Association, I'm going to sit down right here, with strokes, they also want you to be able to recognize the signs and symptoms of a stroke. So remember FAST, right? Facial drooping, arm drooping, slurred speech or slobbering, and then T stands for time. So FAST, facial drooping, arm drooping, slurred speech or slobbering, and then time. Okay, so those are kind of our signs and symptoms. There's other signs and symptoms of a stroke too, right? We all know this, right? The eyes can act funny. They can complain of a headache. So you want to know your signs and symptoms of a stroke, not only for the ACLS class and test, but you want to know it as a good healthcare provider as well. And know your stroke protocols for the facility that you work in. All right, because I don't know a facility that doesn't have one. But I do remember when they started putting them into place. So I've been in this business for a while. The next thing that you're going to need to know about strokes when it comes to preparing for this ACLS class and test is just a little bit about, timing of the stroke. So from the door, we oftentimes will take them straight to the cath lab. If they get time in the ER, it's usually no more than 15 minutes. And then we've taken them on to the to the CAT scan room. Scratch cath lab. It's CAT scan room. I'm sorry about that. This is important because I want you to remember that time is really of the essence. So if EMS finds a patient, for example, that's a suspected stroke patient out in the field, the first thing they probably would do is confirm all of the signs that they are a possible stroke patient. Then they might stick the finger and do a sugar check. Why would they do that? They're ruling out the possibility of hyperglycemia. Because can't those signs and symptoms sometimes mirror the stroke signs and symptoms? We do the same thing with STEMIs. We could have a patient with chest pain, shortness of breath, some of the same signs and symptoms of a STEMI, and they get a chest x-ray as normal protocol in the ER. They're ruling out. We're always ruling out in healthcare. But specifically with strokes, they prick the finger, get a sugar check, make sure they're not dealing with hyperglycemia, and then if it's not, then they're pretty sure it's a stroke. They call in a stroke patient, and they want to get straight to the hospital. All right? So from time of onset of symptoms to 3 hours is about the time that we want to start fibrinolytic therapy. All right? So that is a question that I can see them asking. I'm just kind of looking through my notes, making sure that I'm giving you the right information about that. The main thing that I want you to understand is not everyone's eligible for fibrinolytic therapy. So we have to get them from the field, 15 minutes in the ER, asking them questions of things that might make them a contraindication for fibrinolytic therapy. And those things you might want to just review. Have you had a stroke in the past 3 months? Do you have a gastrointestinal bleed? So these are things that you would want to review. What are the contraindications to fibrinolytic therapy? There's not many, but there's a few. Do you take, I think it's called Cialis? It's a long word. I'm not going to try to pronounce it. Don't laugh. But can be a contraindication. So that would be one of the things they're doing in the ER, right? Is questions, getting medical history, getting allergies, getting current meds, ruling out other things. But 15 minutes and then boom, on to CAT scan. What are they looking for in the CAT scan room? A bleed. And hopefully we don't have a bleed. Because if you have a hemorrhagic stroke, well then we have a neurology consult, and that's on him, how he handles that. But with a non-hemorrhagic bleed, we're going to shoot for fibrinolytic therapy within 3 hours of onset of symptoms. We can go up to 4.5 in a non-symptomatic patient, or they're not very symptomatic. We can go all the way up to 4.5. But I don't recall them ever bringing that into the test. That just happens to be in the book. Okay? So remember with strokes, much like STEMIs, what are my signs and my symptoms? And then what are some important things that I need to know? Okay, well, I need to know that this is what they would possibly do to treat stroke. And here's the time that we want to be able to start that treatment. And we've gone over that. So not a whole lot more to talk about with strokes. Know your protocols, that your healthcare facility has. All right. The next component to ACLS, and I go through these fast because we spend most of our time on abnormal heart rhythms, but our next component is airway management. And there's a couple of things that I'm just going to throw at you. The first one is know what an oral airway is, sometimes called a bite block. They're shaped, they're hard little plastic things, and they're shaped something like this. And they go, and so this kind of goes down. The idea is to keep the tongue down. So here's your picture. I know it's terrible. I'm not an artist. But the idea is to put this oral airway in and keep the tongue from falling back. The oral airway is also useful if they are intubated, to keep them from biting on the tube. So I want to make sure you did get a picture of that oral airway. I know, it's good. Stop it. Okay. So oral airways, here's the only thing I have ever seen American Heart ask on a test regarding oral airways, and that is, how do you know what size oral airway to use? So simple if you think about it. Think about it. It's going in the mouth, right? So how about from the angle of the mouth to the end of the mandible? Just lay that oral airway right up there, and the one that's closest to that fit, there's the one. And respiratory will be happy to put it in for you. But just so you know, it never goes in straight. It always goes in kind of sideways, and then you turn it as you're going in. And we do that with a lot of things. Like this next one that I'm going to bring up, the nasopharyngeal airway. That's something you need to know about as far as airway management. That is, you've got your G tube here, okay, because you guys put a GI tube right here. And then you've got a patient that has a lot of rhonchi, a lot of mucus going on, and so you've asked respiratory to come suction. And so what do? Well, we don't want to take the chance to stick a 14 French catheter in his nair one time and suction him, knowing that in 15, 20, 30 minutes, we might need to suction him again, because every time we're sticking that 14 French catheter in the nair, we're really torturing the very delicate mucosal membrane. And it's just so thin and delicate. And so nosebleeds are very real at that point. So what we do is we put a nasopharyngeal airway in that nair. And how do we measure that? This is the question that you will see on the ACLS test. How do I measure it? How do I know what size to put in? You measure from the nair to the earlobe. Just slap it right up there, and whichever one is closest is the one that I'm putting in the patient. And again, that's another one that doesn't just go straight on in. You kind of start off with it on the side, you lube it up real good, start off with it on the side, start to put it in, and as you go in, you turn it. And that's how it's put in. Same way we put the oral airway in. So, but I don't want to get off track. Remember how you size them. To review quickly, oral airways, angle of the lips to the end of the mandible, nasopharyngeal airway, the nair to the earlobe. Okay, make sure that you know those. Airway management is also interesting because we don't, in code situations, do 30 compressions to 2 breaths. In a acute care setting, we do what's called asynchronous ventilation. So if you never knew what asynchronous meant, now you know. We do what's called asynchronous ventilation. And that is you have someone doing compressions at about 1/3 the depth of the chest cavity, 100 to 120 times a minute. Not too fast, not too slow. Okay? And while that's going on, you have the person that's at the airway with their hand covering the mask with a tight seal so that we're not losing any air, and also making sure that their finger is kind of pulling the chin back. So I would take my finger and pull the patient's chin back and use the rest of my fingers to hold the mask on so that I get a tight seal. Why am I holding this chin back? Because I want to make sure the airway's open. And so that person that's up at the head of the bed doing the breathing is doing asynchronous ventilations, which means they're giving a breath about every 5 to 6 seconds. So they're watching the person that's giving the chest compressions, and they're counting 5, 4, 3, 2, 1. They're coming up on the chest, squeeze the ambu bag. They're coming up on the chest, squeeze the ambu bag. So we gave 2. 5, 4, 3, 2, 1. They're coming up on the chest, we squeeze the ambu bag. They're coming up on the chest, we squeeze the ambu bag. We gave 2 more. 5. And we just keep going that way. So every 5 to 6 seconds, we're giving 2 breaths. All right, and that's called asynchronous ventilation. They do that out in the field all the way to the hospital, and we do that in the hospital. Okay, so I wanted you to know it was every 5 to 6 seconds. That was the important thing I wanted you to know. Airway management's important too because I want you to understand the different masks that we have to choose from. One that is kind of new that some of you may or may not have seen is called an oxy mask. It has quite a few holes in it. It's clear. And what I want you to know about it for nurses or someone that's just might be putting that on for respiratory therapy because maybe they can't get there quick enough. There's a cheat sheet taped right on that supply tubing. And that cheat sheet tells you this is how many liters you're going to set your regulator for to achieve this much FiO2. So you set this mask at 5 liters if you want to achieve, say, I'm not sure what the paper says, but I think it's something like 36 to 50% FiO2. But it literally tells you how many liters to set that mask for to achieve a certain FiO2, okay? How do we measure that FiO2? 1 liter is 24%. You and I are breathing 21% FiO2. oxygen. 1 liter is 24%. 2 is 28. 3 is 32. 4 is 36. Do you see where I'm going with this? Every liter added another 4%. So there's something that you learned that you didn't maybe know. Now you do. That's important when you're talking about a COPD patient, because we want to be so careful with how much FiO2 we give to them, right? Let's talk also about the mask called a non-rebreather. Non-rebreathers are something you might see on the test. They're going to ask you something like, what liter flow should the regulator be set at? And the answer is above 10 or between 10 and 15. I'm going to tell you, in the real world, in reality, we typically just take that ball right all the way up to flush or 15, and that's as high as it will go. All right, so that's for your non-rebreather. It's important that you know that ACLS is going to ask you what liter flow should a non-rebreather be at, and it's usually above 10, between 10 and 15. In reality, it's all the way up, right? We want to keep that bag full of pure oxygen. Then the other mask that you might see and want to get yourself familiar with is the Veni mask. If you call a respiratory therapist and say, hey, could you come put a Veni mask? There's an order for a Veni mask. Could you come put that? It might be helpful for you as well as the therapist if you start putting that together for them. Each color-coded piece that comes with the Veni mask has written on it, look at it the next time you see it, the liter flow that you should set the regulator for to achieve what exact FiO2. So if it's orange, it might say 5 liters is going to get you exactly 40% or 42% or something like that. I don't know. I don't have it in front of me, and it's been a while since I looked at one, but there's your cheater right there. It's just a Veni mask is easy to put together. Just make sure you put the pieces together just as the diagram shows you, and then look at the color-coded piece, and that tells you exactly what to put your regulator at for the FiO2 that you're trying to achieve. And then when the respiratory therapist gets there, just say, I put it together. Can you look to make sure I did it right? And if I did something wrong, would you let me know? It's a great way to learn. And don't ever get rid of the little round cup that comes. It's a little clear cup with a hole in the bottom, because we put that at the bottom of the color-coded piece, and that is to keep the FiO2 at its exact point that we want it to be at. All right, without that little round piece, you can have a respiratory therapist in your facility explain it in further detail, but it's there to protect that patient from not getting the right FiO2, okay? So let's review those masks. We had an oxy mask, we had a non-rebreather, and we had a Veni mask, okay? Remember with nasal cannulas that if they're on 3 liters or above, be kind and put some humidity on there for them, because it can be very drying to the nose. So typically I'd say the rule of thumb is 3 liters or higher. Used to be 4 liters or higher. I think we're really starting to put humidity on at even 3 liters now. So be kind with that. Never go over 6 liters on a nasal cannula. That could be a question or a trick question on your ACLS test. Never over 6 liters for a nasal cannula. At that point, you want to consider a mask. Probably either an oxy mask or a Veni mask. Okay? Remember what I told you. It's every 5 to 6 seconds we give them a breath. And that's for rescue breathing too. All right? Finally, with an ambu bag, it goes flush, just like I said. It goes all the way up. Never, ever, ever, if you work in a skilled nursing facility, use a concentrator, even if it goes to 10 liters. Never, ever, ever use a concentrator for an ambu bag or a non-rebreather, for that matter. Never. Non-rebreathers and ambu bags all go flush, 15 liters. But the answer might be 10 to 15, and that's perfectly acceptable. But if you work in a skilled nursing facility, I have seen nurses that just didn't know have a concentrator hooked up at 10 liters with a non-rebreather or an ambu bag, and it's just no. So what do you do in that case? Grab an e-cylinder and put it at 15. Okay? That's all I want you to know about airway management. Don't forget your oral airway, and don't forget your nasopharyngeal airway. Okay? And so we have just discussed in a rather short amount of time 3 topics that encompass ACLS. And there's only one more, and that's abnormal heart rhythms. And that's where it gets fun, because you're sitting there thinking, Michele, what about these algorithms? What about this pharmacology? What about, well, that is where a lot of all the questions come from, is these abnormal heart rhythms. And I just love teaching this. So we're going to go ahead and just jump right into it. What you have, the PDF that you should have in front of you right now is right here. Okay? Because we're going to draw this on my board, or I'm going to draw it on the board while you look at yours, okay? And then you can take notes, things that I say that perhaps I didn't type on here or that you think were important. Go ahead and write those on that PDF, okay? Now, let's make our 3 circles, because we're going to take those 4 pages of abnormal heart rhythms, and those are the most common used heart rhythms that we see even in the clinical setting, but B, that American Heart would normally use on the test. Those are your common heart rhythms that you'll see on the test. So those are important. Don't lose those 4 pages. Okay? So we're going to take all 4 pages and we're going to divide them into 3 categories. Meaning that we really only need to focus on 3 algorithms, or what I like to call 3 care plans. And I'll show you how that's done. So I'm drawing my circle: tachycardia, bradycardia, and pulseless. Okay? I'll stand back. You see my 3 circles are not artistically done at all. But you have a PDF right in front of you with the same thing. And what does it say? It says we put a T right here And that stands for, that's our tachycardia circle. And so right now, we're going to go ahead and look at those 4 pages of abnormal heart rhythms. And I'm going to go ahead and lay mine out too. And we're going to find all the tachycardia abnormal heart rhythms that we can find. And we're going to put them in that circle. Okay? It's that simple. So, let's start with number 1. Is it fast or slow? Well, it's fast. So, right there, you know that's a tachycardic rhythm. All right? And then I like to pick the pieces apart to find out what type of rhythm it is. Is it coming from the ventricles? Is it coming from the atria? Who's the culprit, so to speak? Well, I look at it and I say, does it have, let me find my thumb or my finger. Let's see. Right there. Okay. Does it have a P, a QRS, and a T wave? That's what I like to know. Do you see a P, a QRS, and a T wave? There we are. A P, a QRS, and a T wave. Because if we come over here, and I have it right up here. If you look right here, you see no P, no QRS, and T. Or yes, you do see a QRS, but you see no P and T perfectly defined. What you see is a possible P or T right here. You do see a beautiful QRS, so you know your ventricles are behaving themselves. No P or QRS or T there. No P or T there. No P or T there. And it's a highly fast rhythm. We know that because we can count 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 is probably close to 180. 180 is pretty fast. I'm thinking SVT because we've got a tachycardia without a P. We might have an SVT. Do you like that? I got a tachycardia without a P. I might have an SVT. True, true, true. Look right here. Same thing. I got a tachycardia. It's number 5. Number 5, guys, SVT. It's a tachycardia even faster without a P. I probably have an SVT. Let's go down here. This one's tricky. This is so fast. It's definitely an SVT. And this patient will be symptomatic. But I'm jumping ahead of myself. But here I have a tachycardia that does not have a clear-cut P. I probably have an SVT. Here's what I'm going to tell you. If I gave this patient right here, because I would argue this one a little bit because there is a little bit of a P wave there, just a teeny tiny one. But I argue it a little bit because if I gave this patient some adenosine and slowed it way down, I bet you that P wave would present itself twitching. Have you ever had an eye twitch? The atria is a muscle. The P wave represents our atria. So if it's twitching, the atria is probably the culprit. But this AFib has been let go for a while or gotten out of control quickly, and it turned into superimposed, shall we say, by SVT. So we have found 3 SVTs, right? Number one is SVT. Number 5 is SVT. And I believe this is number 6, 7, 8. Number 8. Okay, so there's your 3 SVTs. Now I'm going to go ahead and write SVT in my circle. And you see on your PDF printout that I have SVT. And we've identified 3 SVTs. Okay? And SVT is just, it's difficult because so many things can cause it, right? Anemia, hypokalemia, hyperkalemia. It's not age specific. 17-year-olds can come in with SVT. Okay? So before we go any farther, let's finish finding some abnormal heart rhythms that fall into our tachycardia circle. Okay, our tachycardia circle. All right. Well, I'm thinking that our next set of abnormal heart rhythms is going to be hopefully something simple. Oh, here's a nice simple one. How about I believe it's number 11. Number 11. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13 times 10. About 130. There's your P, there's your QRS, there's your T. All looks regular. I've got a sinus tachycardia. That's the easiest one to pick out. If you can't pick that one out, call me. We got to do a class over the phone. ST, sinus tachycardia. That's the next one you see is an abnormal heart rhythm that falls into your tachycardia circle. Then you've got number 15 and number 19. I want you to look at these kind of at the same time. Because fortunately, there's only 2 abnormal heart rhythms that we could honestly say the atria is responsible for those abnormal heart rhythms. And again, we're not going cardiology deep. We're staying surface ACLS and what ACLS wants you, what American Heart Association wants you to be familiar with, okay? So 15 and 19 are great examples of 2 abnormal heart rhythms that are atrial in nature, meaning the atria is the culprit. Watch this. Too much shadow. Okay, watch this. There's your heart, right? I'm going to break it in half. Here's my P wave. There's my QRS wave. Atria, ventricle. So I like to say my P wave oftentimes makes me suspect I have an atrial abnormal heart rhythm. And number 15 and number 19 are just great examples, right? So if we look at number 15 right here, we see that we have beautiful QRS waves. So I know that my ventricles are not the culprit for the fast rhythm that I'm seeing on the telemetry screen. You know, it's like 152, 147, 160, 146, 154, 155. It's kind of a little all over the place, but it's staying tachycardic. And it's not the QRS's fault. He's pretty. right? They're pretty. But your P's are not so pretty. There's way too many of them, guys. Way too many. And so we learned in school that if it looks like a sawtooth pattern, it's atrial flutter. And that's exactly right. So I'm going to add atrial flutter to my board. And you have that on your PDF, atrial flutter. And then number 19 is the opposite of atrial flutter. And I'll share it with you, and then I'll tell you how you can easily notice the difference between fib and flutter, okay? So down here, we have our number 19, and we've got a fast rhythm. The telemetry screen is showing me somewheres around, 160, 177, 156, then it's back up to 180. It's kind of all over the place. And, it's like beat, 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 beep, beep, beep. It's not a regular beep. I know you've palpated the pulse of an AFib patient. You can't miss it. It's not a regular rhythm, right? So that's the first thing, and that's why I circled that right there. You can see I circled it because that's your run of irregularity right there. But the other thing is, again, I'm picking it apart. I have a tachycardic rhythm, but I have nice looking QRS complexes. But then when I go to try to pick out my P and my T's, I see that my P's are kind of twitching. They're twitching. They're kind of just twitching. Let me get my pencil. I can show you a twitch easier. They're twitching. They're twitching. They're twitching. See right here how it's twitching. It's twitching. It's twitching, right? And so when you have a P that's twitching, kind of like you have a muscle that's twitching, 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 it's recorded and then represented on paper just like this. And so you know that a twitching P is typically going to be atrial fibrillation. Twitching is kind of fibrillating. It's fibrillating. So there's your atrial fibrillation. Let's write that into our circle of abnormal heart rhythms that fall under tachycardias. Now, I promised you I was going to show you a real simple way to always know the difference between AFib and aflutter. I mean, there's gobs of ways that you can tell the difference. I mean, flutter looks like the sawtooth, fib does not. But the real thing is, flutter will oftentimes be a nice regular rhythm. Fibrillation will most of the time have runs of irregularity. And that's like your pick-off sign right there. Okay? All right, now, there's only one more abnormal heart rhythm that we have to go over for tachycardia, and that is found in number 17. Number 17 is found right here, and you see it on yours, and I've got it here on mine, and this is just no QRS, no T, or I'm sorry, no P, no T, just straight QRS. Just straight QRS, isn't it? Straight QRS. Who's the culprit? The ventricle. So what is this? VTAC. It's VTAC. What does VTAC look like? Number 17. VTAC. Okay? So, it's one shape. of VTAC. It's monomorphic because mono means one, morphology means shape, one shape of VTAC. Monomorphic VTAC. And yes, I am going to put that in the tachycardia circle for now. But she's interesting because she can actually go in two circles. And I'll show you what I mean as we go along. But mono VTAC is our last rhythm for tachycardia, abnormal heart rhythms. Now, we're going to take a break, and there is something I have to tell you. For this to all come together and a light bulb to start glowing, there's two questions that you always have to ask yourself. You ask them anyway. It's silly to even have to write them down, but you ask them anyway, and you see them on your PDF printout, number 1 and number 2. Number 1, is my patient symptomatic? Right? Or is he unsymptomatic? That's number 1 question, and you're asking it. You don't even realize you're asking it, but you're asking it. And number 2 is even a sillier question, but does my patient have a pulse or no pulse? Because listen, guys, the answers to those 2 questions that I wrote at the top of that PDF is how you're going to be guided through the algorithms or care plans of these abnormal heart rhythms. So when you identify an abnormal heart rhythm, you immediately ask one of these questions. Okay, so let's take an example. Let's take sinus tachycardia as an example. Is he symptomatic or not? Well, he could very well be unsymptomatic, right? But if he was symptomatic, Michelle, what would I see? What would I see? What are you talking about? Well, I want you to write it because it looks like some of it might have got cut off. But the first one is, how about low blood pressure or low BP? Right? How about altered mental status? That's a big one. That's a big one. How about low pulse ox? And then finally, how about those subjective signs and symptoms that we here in the United States tend to really not pay attention to because we're so focused on those pieces of equipment? Your patient could be saying, I feel so lightheaded, sweaty, and I can't catch my breath. Boom, she's symptomatic. She just told you so. You didn't need a machine to tell you that. You could look at her cap refill. You could look at the color of her skin. You know, you can ask her questions. And so these are subjective symptoms that help us decide if our patient is symptomatic or not. But with ST, we asked ourselves, is our patient symptomatic or unsymptomatic? Do they have a pulse or no pulse? Because if they don't have a pulse and you see sinus tachycardia on the board, oh boy, we go in a whole different direction, don't we? Yes, we do. We go into PEA. And we're going there. Now, I want to pretend that our sinus tachycardia patient is showing a blood pressure of 95/66. She's complaining of feeling a little lightheaded, and maybe short of breath. Okay? And so you're going to say, check mark number 3, she's symptomatic. She's symptomatic. She's got 3 strikes against her. She's symptomatic. And she has this abnormal heart rhythm. So, hey, doc, I've had this patient since 7 a.m. In report, I got some information that she had some runs of tachycardia here and there throughout the night, but nothing to really get alarmed about. She remained unsymptomatic. So they did pass that on in report. In the last hour, she has become tachycardic and remaining tachycardic. Started out slowly at like 130, and then it's just kind of creeping its way up, and it's creeping me out because she's becoming symptomatic, right? And so I went into the blood work that you had ordered to be drawn this morning, and I noticed that her WBCs are up, and maybe, I don't know, some SEGs or lymphs or something was up too. And the doctor says, I stopped and saw her x-ray on my way out of the hospital this morning, and I noticed that she had some infiltrates in her left lower lobe. Well, there might be your explanation for your sinus tachycardia. So this is what I wanted to share with you. The ACLS book, I think, if it's read chapter to chapter to chapter and not really looked at as a whole, sometimes can make us think that there's a one-size-fits-all approach to each and every abnormal heart rhythm. And that's just simply not true. It's just simply not true. I want to show you something. I'm going to draw another heart. Pretty heart. We approach, and you see this on your PDF printout, correct? And you see 4 arrows pointing at the abnormal heart rhythm, right? We approach abnormal heart rhythms from all different directions. So in the case of the patient that has some elevated WBCs, has a few symptomatic signs, doctor says there's an infiltrate, he might say, hey, let's go ahead and be proactive and start her on an XYZ antibiotic. And let's go ahead and give her some saline as well. Let's get that volume back up. And so, we go ahead and start on some antibiotic, and we go ahead and give her some saline too. And these 2 little ways that we attacked her sinus tachycardia could just be the ticket to ending that sinus tachycardia completely and putting her back into a sinus rhythm. And you could say that with any one of these abnormal heart rhythms that we've found in the tachycardia circle. SVT, same thing. If we are proactive and we're able to find what the underlying problem is, sinus or SVT. Underlying problem, doc, we believe is a fib. Okay, I want you to go ahead and give her an amiodarone bolus and then drip it. Put her on some saline as well. Let's get that pressure back up. You may just get rid of that SVT because you got rid of the underlying problem, which was AFib. So do you see where you could approach these abnormal heart rhythms from a proactive standpoint before you ever have to get down and dirty with the ACLS algorithms? We always want to try to cut them off at the pass. Now, if your best efforts to stop that abnormal heart rhythm and convert it back to a normal sinus rhythm were not successful, then we have to consider what is the algorithm for tachycardias according to the American Heart Association. And so you'll see right underneath the circle, I write it for you. And so I'm going to go ahead and write it up here. The doc says, so for our AFib patient that we gave the amiodarone to, and how's she doing? What's her symptoms now? Well, she's still running with SVT, and she's more symptomatic now. She's actually her blood pressure is dropped even a little more. She's got some altered mental status. I think she's a little worse. He says, I'm coming off the elevator. Can you grab the crash cart? We're going to go ahead and deliver to her 6 milligrams of adenosine. You see that right there on your PDF printout, and or 12 milligrams of adenosine. Why? Because we weren't able to convert her back being proactive. Okay? So we're going to try adenosine first. We tried bearing down. That did not work. We tried she was, kind of out of it, wasn't waking up. So we put a cold washcloth in ice and got it super cold and then slammed it on her face, and that didn't work. So, we did everything we could proactively to get that rhythm converted back, but it's just nothing fixed it. So that's when the algorithm or the care plan, the ACLS care plan, comes into play. And doc, at this point, with a blood pressure that's not dangerously low and she's not, completely out of it yet, he decides, okay, we've got some time. Let's go ahead and try the adenosine. But before he gets in the room, just as he enters the door, you look up at him, and you've got the 6 milligrams and the 12 milligrams of adenosine laying out on the cart. But you look up at him and you say, Doc, her blood pressure just dropped to 80/40. And he says, forget the adenosine. We're not even going to try that. We're going straight to cardioversion. Do you see that on your PDF printout? Why'd he do that? We're not have time to mess around with the medication. We're going straight to the electricity. We're going to just go ahead and cardiovert her and get her converted back to a normal sinus rhythm. Okay? So, if she hadn't started to get really symptomatic, we would have attempted to give her the adenosine and see if that worked. But she got too symptomatic on us. And by the way, when you go to give the adenosine, in the state of Florida, I don't know how it is in other states, but in the state of Florida, if a doctor's not in the room, you don't give it. And when you do give it to the IV that's closest to the heart. And if that happens to be the one in the hand, give the adenosine, then flush it, and then hold the arm up. That's how you deliver adenosine. Okay? Now, had she not gotten so symptomatic on us, we would have gone ahead and done the adenosine first. But we don't go in that order just because that's what the book says. We have to use our heads and go, wait a minute. If she becomes super symptomatic, we may just have to forego and waste our adenosine, and we're going straight to cardioversion. Now, that's written on your PDF printout. Underneath cardioversion is a 1 and a 2. What makes cardioversion different from defibrillation? Because they're the same machine. It's the machine that sits on top of the red cart. We call it a defibrillator. But it actually operates in 3 different ways. It can cardiovert, it can defibrillate, and it can pace. It depends on what we tell it to do. So, there's 2 things underneath cardioversion, and that is what makes cardioversion different from defibrillation. Number 1, we sync the shock. What do you mean sync the shock? Good question. Right here, do you see where I have a red line right above the QRS wave? That red line is actually indicating that the energy is going to be delivered at the peak of the QRS wave when you press shock. So when you hit the sync button, you told the machine, hey, when I hit shock, I want you to deliver the energy at the R, right on the R, because that's how you're going to stop, reset, and convert my patient back to a normal sinus rhythm. And that's what syncing's all about. The other thing that makes syncing different from defibrillation is the fact that we don't use near the joules in cardioversion that we do in defibrillation. In defibrillation, we can use up to 360 joules, correct? Yeah. But with the biphasic. But in cardioversion, we use approximately 100 joules, okay? There's an exception to every rule, and I did not make the rules. I am only the messenger. So, don't get mad at me. I did not write this on your PDF printout, so get your pencil or pen out. And right where you see, and I'm sorry this is backwards. If it is, I'm going to hopefully be able to revert it after I'm done recording. But right here on AFib and AFlutter, you see those 2? I want you to put a little arrow kind of connecting the 2. And beside it, I want you to write 50 to 70 joules. Right beside the little connector, however you wanted to do it. AFib and AFlutter only get 50 to 70 joules of energy. You give them too much, you might be in for some trouble. Okay? They don't like a lot of energy. They're just little tiny atria in comparison to the big mighty ventricles. So keep that in mind. 50 to 70 joules for your atrial. Okay? So there's one more tachycardic that we did not put in that circle, and we're not going to put in that circle, but I want to go ahead and get it out of the way and show you where it does go. And it's number 7. It's monomorphic VTAC's evil twin sister. Her name is Polly. Poly means many. Morphology means shape. Many shapes of VTAC, right? So Poly, number 7, has a whole lot of shapes of QRS waves. So we call that polymorphic VTAC. You can even see there towards maybe a third of the way through a little run of 5 QRS waves that are kind of all the same. They look the same, maybe a little spindly at the R. That's called torsades. If you ever wonder what torsades looks like, circle those 5. And I'm going to hold my phone down, and I want to show you what I'm talking about. So, right here is your torsades run. Okay? Now, that is polymorphic VTAC. And polymorphic VTAC was cast out of the tachycardia family many, many years ago. Matter of fact, polymorphic VTAC was placed, as you see, down there with VFib and pulseless VTAC. So we place her with VFib and pulseless VTAC. Okay? So we're pretty much done with tachycardias. You've learned a lot so far. You've learned how to recognize all your abnormal tachycardias. You've learned the algorithm or the care plan for the abnormal tachycardias, and when it's appropriate to use that algorithm, and which piece of that algorithm is appropriate to use. Do we use the whole thing or just a piece of it? Well, in some cases, just a piece of it, right? Remember the lady that, we went ahead and wasted the adenosine and went straight to cardioversion? Remember her? We just used a piece of that algorithm. Okay? So we also learned that once we identify an abnormal heart rhythm, we ask 2 questions. Is the patient symptomatic, unsymptomatic, or do they have a pulse or no pulse? Because that helps guide us as to where we're going to go. Are we going down there to pulseless electrical activity? Mega code question for you. Here's a question I can see being on an ACLS test. Right here. You've got number 17 on the screen. Everybody look at number 17. Monomorphic VTAC. Okay? She's symptomatic. That's question number 1. Answer's yes, symptomatic. You ask question number 2, and she has no pulse. Symptomatic, no pulse. Do we still cardiovert that lady? Is she still going to be treated the same way we treated all the other tachycardia, abnormal heart rhythm? No. No. Here's the example. This is where monomorphic VTAC can be tricky, and she has a whole nother personality. She can go down here. Did you ever wonder what pulseless VTAC looks like? Look at number 17. She's symptomatic and she has no pulse. What is that? Pulseless VTAC. In that case, we start CPR. So that's how monomorphic VTAC can be dual. Okay? And I just want to be the one to tell you that on the tests, they use monomorphic VTAC a lot because of what I just told you. Because she can be symptomatic with a pulse and need to be cardioverted, or she can be symptomatic without a pulse and need to be defibrillated. And that is a question on the test. So be sure you understand monomorphic VTAC and how she plays dual roles in this ACLS extravaganza. All right, guys, let's go to Brady's real quick. Don't want to spend a lot of time on Brady's. Really don't. You're going to hate me for this, but, well, you won't hate me for this one. Just tell me what number 9 is. Look at number 9. Well, you see on the printout that I gave you that it's a sinus bradycardia, right? Number 9 is a sinus brady. I see a beautiful P, a beautiful QRS, a beautiful T. It's just a little slow. So we're going to put that it's a sinus bradycardia. And you know, for a lot of people, sinus bradycardia, perfectly fine. They are not symptomatic, and they just live that way, or sleep that way, or have runs during the day where they might be sinus bradycardic. But when they become symptomatic with a pulse, how do we treat them? Well, as you see, I wrote at the bottom of that circle 1 milligram of atropine. They changed, American Heart Association changed that this year from 0.5 milligrams of atropine to 1 milligram of atropine. Okay? So once your sinus bradycardic patient becomes symptomatic with a pulse, because if they're symptomatic without a pulse, where are they, folks? PEA, I'm going to keep asking you this, because I want to see if you can quickly help those two questions guide where you're going and how you're going to treat them. Okay, but in this case, this patient's got a pulse, but he's symptomatic. So doc's going to order 1 milligram of atropine. That's right. 1 milligram of atropine. I write it on my board while you look at it on your PDF printout and take notes, okay? Now, let's find some more bradycardic abnormal heart rhythms. Will you say, Michelle, there aren't any more? Well, there are. And those are called sinus, or they're called heart blocks, okay? And so a lot of people, heart block, I never can understand. Well, they're easy. They're easy. Look, I'm going to show you how easy they are. They, first thing I need to tell you is the heart is like a pool pump, all right? It operates off 2 main components. Number 1, it operates off mechanics. All the valves have to be opening and closing correctly. Tricuspid, right? The water line to the pool has to be patent. You can't have some kind of rodent in there that's built a nest, or no water's going to get to the pool, and then the water won't circulate in the pool, right? So the heart also has mechanics in nature. The arteries have to be patent. Your valves have to be working correctly. And so that's the mechanical part or component of the heart. There's a second component of the heart that's very similar to the pool pump, and that is the electrical component. I plug my pool pump into the house to give it electricity so that it will begin to circulate my water, assuming that all the mechanics are running correctly. The heart also has its own electrical system. And if it's not working correctly, you have a heart block. Heart blocks are electrical in nature. If you understand this, heart blocks will never be hard for you anymore. Do you think an MI is an electrical problem? No. That's a mechanical problem. A heart block's electrical. Let me show you. I wished I'd done a printout of this, but I didn't. Let me see if I write it in red, if it will show, or maybe dark blue, it might show up better. I'm going to draw a heart up here. I hate that shadow. But I'm going to draw a heart right here. Okay. See the blue heart? Now, you remember in AMP 101, we had the SA node to the AV node to the bundle of His to the Purkinje fibers. Do you remember that? And what connected them? Little lines. This SA node is actually called our natural pacemaker. This is all the electricity that runs through our heart and makes it work. And so, when the SA node kicks out, the AV node kicks in. When it kicks out, this kicks in, and so on. Not only that, did you saw the lines that connect these? I want to give you an analogy of what those lines are like. Let's pretend that I built this wall right here. And before I put the sheetrock on the wall, I had to run some electrical wires down the wall so that at the bottom of it, my electrical outlet that's supposed to be right here would work, okay? But, and I did. I went ahead and ran some electrical conduction wire all the way down the wall to the electrical outlet. And then I went ahead and put the sheetrock back up and painted it, and it was beautiful. But wintertime came, and some rodents were in the wall, and they wanted to get warm. So they crawled their way over to the electrical wire that I had put in the wall, and because it's warm, right? It's got electricity coming through it. And they nibbled on that wire. Because if rodents don't nibble something, their teeth will outgrow their body. Look it up. Anyway, they began to nibble on my conduction wire that fed juice to my outlet. So I come in and plug my laptop into that outlet, and I've got to wiggle the plug, or I've got to bang on the wall to get juice to come to my laptop. Why? Because I have a conduction block in my wire. Because that rodent nibbled and caused a block in the wire. And do you see where I'm going with this? This is the same thing that can happen when you get a block in a piece of the wire, if you will, that runs from the SA to the AV to the bundle of His to the Purkinje fibers. Say it one more time. SA node, AV node, bundle of His, Purkinje fibers. That's your electrical conduction system. Now let's add to that I told you earlier, the P wave is represented usually, typically, by the atria up top here. And the QRS is represented by the ventricles. Now just keep this in mind, tuck it, write it down. It'll sink in. A light bulb's getting ready to snap right on for you, I promise. Now, this is how easy blocks are. Matter of fact, I'm going to keep the blue going because it's working for me. Take your papers to 10 through 14. Okay? American Heart Association and ACLS really only expects for us to be able to recognize and understand second-degree heart blocks and third-degree heart block, okay? So there's a freebie for you. You don't have to worry about junctionals or first-degree block, okay? So that's good. So let's just talk about second-degree blocks. How do I identify them, Michelle? How do I know what they look like? Well, here you go. A second-degree block is typically a bradycardia that drops a QRS complex. It's that easy. So you mean to tell me if I go into my patient's room and I look up at the monitor and go, oh, geez, he's in bradycardia. Oh, and he's dropping a couple of QRS complexes. He's in second-degree heart block. He is. He is. And so, next to second-degree heart block, I want you to write bradycardia that drops QRS complexes, because I'm going to. A second-degree heart block is a brady that drops a QRS complex. And it just keeps doing it. It just keeps going on and on and on. The problem is there's two different types of second-degree heart blocks. There's Mobitz 1 and there's Mobitz 2. No big deal. No reason to panic. Do not alarm. Because the difference between the two is found in the relationship between the P and the QRS wave. Look at number 13. Okay? Now, number 13, what do we see? Oh, where's my pencil? There it is. Okay. Number 13, what do we see? We see that we have a little P wave right at the very beginning. Right here, we have a little P wave. See where my pencil's pointing? Okay? Now, get your protractors out. Just kidding. But pretend, because we know that the big boxes are 0.20 seconds. Remember that from school? All right. So, the P to the QRS, the P sent a memo to the ventricles, and it took, according to my protractor, about 0.20 seconds for the ventricles to get that memo and respond. T wave went, okay? Now there's your P wave right there. Now I put my protractor between the P and the QRS, and I see that the atria sent another memo downstairs to the ventricles, and I put my protractor up there and see it took about 0.24 seconds for the ventricles to respond and create a complex. T wave, P wave. Protractor says this time they sent a memo and it took about 0.30 seconds for the ventricles to get the memo and respond with a complex. T wave, P wave. I'm trying to circle this. Do you see? Maybe if I do it in blue, you'll see it better. It dropped a QRS complex. So, I'm not a poem person, I'm a Y person, but I will use the poem in this example. The P to the QRS relationship in time was long, then it got longer, then it got longest, then the complex dropped. Then we start all over again. The P to the QRS is long, then it got longer, then it got longest, and then it dropped again. And it just keeps doing that. Second degree heart block, Mobitz 1. The P to the QRS relationship in time gets long, then longer, then longest, then drops. And it keeps going on like that. Then you have the Winky Bach. That's the poem. Long, longer, longest, drop. Then you have the Winky Bach. Okay? So second degree heart block Mobitz 2 is just even easier, because if you look at number 10, you can see if we're saying that a block is determined by the relationship between the P and the QRS complex, then look, number 10, the P to the QRS complex is literally the same every time I measure it with my protractor. Now, I mean, it's a given. It's a second degree heart block. It's a bradycardia that's missing QRS complexes. We've already established that. But I had to determine if it's a Mobitz 1 or Mobitz 2. And I know it's not a Mobitz 1 because it's not doing the long, longer, longest drop routine. It's actually, the P to the QRS is the same every time they're together. And that's what makes it a Mobitz 2. Easy. Now that you see how easy that is, heart block 3, or a complete heart block, is even easier, because a third degree heart block if you notice on number 12, always has a complex going on, a QRS complex, little wide. We don't like wide complexes. They indicate something's going on cardiac-wise. But there's always a complex there. It's a bradycardia. But my relationship between the P and the QRS, again, is all over the place. Look at the time that it's taking for the P and the QRS to communicate between each other, segment to segment to segment. It's different in every segment. They're all over the place. So we say the P to the QRS is disassociated. And that's what makes it a third degree heart block. And your patient will be symptomatic. And that's not something to play around with. You're usually typically going to either bedside pace them or quick get them downstairs so they can get a transcutaneous pacer, or even possibly a permanent pacer. Okay? You don't need to write that down, because you see at the bottom of the circle on your PDF that I wrote PACE. Because I have a question for you. If a patient has an electrical problem like we just discussed, do you really think the doctor's going to order atropine to fix that electrical problem? Or do you think he's going to want an electrical solution? Probably an electrical solution. Now, it needs to be said that off to the side of the circle, I need you to write, it is not uncommon for a doctor to ask you, here's PACE, all right, for an infusion of epinephrine and or dopamine, okay? Now, that is not uncommon. So be prepared for that. It's common. It's in the book, off to the side, in little tiny letters, but I want you to know that it is common. An infusion of epi or dopamine has been asked in addition to pacing. Now I'm going to erase some of this nonsense now because I want you to see that good and clear. Okay? So you see we used atropine when we had the sinus Brady, then we went to pacing, and we can even give an infusion of epi and dopamine if we need to. Okay? And so there's your bradycardia. Wasn't as hard as you thought. The last that we have to talk about is our pulseless rhythms, which are so easy because BLS always comes before ACLS, just like I wrote in that last circle. And so let's get ready to go to our last slide.